So finally I begin. Well, we are going to come back to the age group where anticoagulations are never administered much. So no hassles about all that. As I can see with the time, I just want to share certain concepts with you rather than going into each and every block here. My topic is to take you in the world of peripheral regional blocks in children. Now look at this. Many of you all might have met him before. Post-operative period, 1.5 hours. He was crying. Now he takes a bottle and suckles. But still we wonder whether it was really pain or he's temporarily pacified with the milk that has been given. So we test his operated limb, which was done under a sciatic block. And now we test his limb, which wasn't operated and given a block too. So this is what peripheral regionals in children are all about. Because we might have certain backs of this kind, we may not be able to administer central neuroaxis. This is intense amount of scoliosis that has happened because of severe scarring after severe burns. This is what the spine has become. And now let me tell you one thing. Hardcore pediatric anesthesiologists do not give awake blocks. We always take children very gingerly inside the theater with pre-medication, induce them and get going with our blocks. Certain blocks that we are going to look into, and I'm going to simply highlight what message I would like to share with you all when this subject is spoken about. Interscalene blocks, these are the indications, the sprinkled shoulders or the humerus remains almost the same, but these could be the issues. Look at the contracted shoulder here. Look at the boggy neck here. Well, even adults can be boggy. So this is the small brachial plexus. You need trained eyes to see it. This is the needle sitting next here, and that's the drug spread. Continuous techniques are possible. Now we have spoken, see, this is the brachial plexus around, and you can see the Tuhi needle. Well, one take-home message here is, if you are well versed with ultrasound, if you're very sure about what you have seen, probably it is not then necessary to go and confirm whether what looks like a nerve behaves like a nerve too. So if I'm seeing the brachial plexus so pristinely, and so is the needle next to it, and I'm sure about my scan and sonoanatomy, and I'm going to see the catheter right walking out of the Tuhi needle tip in front of me, I probably do not need other modalities. But of course, there are certain blocks which I wouldn't do without two modalities. And let's see which they are. This is how an interscalene continuous would have been secured. Different ways of doing the same. But the problem in pediatrics is, though they don't always remain in place, children are wriggly, they kind of take it out and give it to you later again when you go to see them in the next visit. Supraclavicular, there is a new surge of these blocks with ultrasound around because previously they weren't practiced too much due to the pleural dome that is then in the neck. The concept remains the same, it's just that now we are working at far superficial levels. Ultrasound guided infraclavicular, again I insist that if this is the kind of sonoanatomy I'm going to see, I don't need any other modality to tell myself that this is a lateral cord indeed, this is the medial cord indeed. And yes, I may not really vouch for this being the posterior cord because I also know that ultrasound gives me artifacts. So if this is the artery, this could be a hyperechogenicity which is now put in front of me as an artifact because a very translucent structure has been traversed by the ultrasound. Look at the pleura, it's so close here. So yes, it does make me thank myself for knowing ultrasound. But read the scans well, otherwise they can be misguiding. So it's as good as the reader. Now, okay. I wanted to show you all the stimulations possible with both the modalities. Here it goes. These are the stimulations. And after giving such kind of anesthesia, for a couple of cases, I realized that that stimulation was not quite necessary when the scan is pristine right in front of you. There was a discussion in the morning, I think Vaibhavi had asked this question, that when the anatomy is not proper, then what do? Well, depend upon the ultrasound at that time to show you what the structures are beneath the skin. At that time, probably you're far more surer as to where you're going. And then, yes, of course, get on with your nerve stimulation modality if that is what you're comfortable with. But here, science is giving you one chance to see underneath the skin. So please don't lose it. This was, anyway, this study was spoken about. This is another, I thank this subject, and I thank that I have gotten trained in this. This is how the ischemic hand of a neonate presents. Look at the you look at this, the artery here. Now, if this is what the ischemic hand was, and if I was to cause another damage at the proximal level, it would have been a disaster. So with ultrasound, yes, I do see the artery, and I do then not damage it. The result is in front of you. It has kind of avoided an amputation to that extent. Now, this is a child. She is a cardiac case, operated, so obviously she is better than what she was before. But anyway, comes for hand surgery. Congenital anomalies come in packages. They don't come alone. So there would be many, many other issues along with it. This is a scoliotic child, again, with a hand case. This is how this spine is. And so now you can imagine how easy or how difficult it would be to palpate her coracoid to give the coracoid plex, the coracoid block, the infraclavicular coracoid approach block. Yes, it would have been easy, very well, but now, knowing the spine and what has happened to the thorax, I really wouldn't vouch at what depth the pleura would be. Hand, again, let's go to axillary. Now, if this is the axillary artery, which I am so sure of, and this is the drug spread, which I am so sure of, if this is the needle, which I am again so sure of, and if this is the spread that you have right now witnessed, and if everything is right in front of me, again, I ask myself, do I need anything else? These are my thoughts, so I just want to throw them at you. Multiple blocks, as you give your blocks with ultrasound guidance, and you see the area flooded with the local anesthetic, there comes a time you ask yourself, should you really be injecting this much? And of course, if you want to give more than one block, this property of ultrasound needs to be exploited. You can give a lesser volume and go ahead. So this is a case of multiple blocks. Lumbar plexus. This is one modality, or rather this is one block where both the modalities are essential. Let me confess, ultrasound shows everything else other than the lumbar plexus. But it's important to note that it shows everything else, because in children, this is a very advanced block, and it's very necessary to see at times the structures such as kidney around, and to know that where the peritoneum has started. Hip are the congenital dislocations of hip are the most sought after cases for this. This is how it happens with dual modality. This is out of plane. I have done a scout scan, and that's how a lumbar plexus block is all about. And I'm that way, I'm sure where the lumbar plexus is, which is shown to me by nerve stimulation, and the path is being told to me by the ultrasound. A sure shot lumbar plexus, or even epidural for that matter, if that is what you're more comfortable with, is quite a nice way to go with children who have hypoplastic lung diseases and then again would have congenital hip dislocations. As I just told you, they come in packages. Anomalies come in packages.